honored today to present my poster to you titled The Effects of Home-Based Palliative Care on Measurements in the Oncology Care Model Program. The Oncology Care Model, further referred to as OCM, is an episode-based payment model developed by the Centers for Medicare and Medicaid Services, also known as CMMS, in order to improve the quality of care for patients with cancer at a lower or the same cost. In order to address the individual and societal burdens of cancer in the United States, the OCM was introduced as a 5-year model between the year 2016 and 2021, whose purpose is to test payment strategies designed to produce higher quality of care, lower costs, and better outcomes. 175 practices across the United States initially participated, and now more than 190 practices are participating in this model of payment. When a practice participates, they must provide enhanced services while collecting data looking at 12 quality measures, of which performance-based payments are calculated. Many of the quality measures, including hospitalization during a 6-month episode, emergency room visits during a 6-month episode, proportion of patients who are admitted to hospice for 3 days or more, chemotherapy in the last 14 days of life, and pain assessments can all be enhanced with support from a palliative care program. Since 2016, Snowline Supportive Care, a home-based palliative care program with a full complement of an interdisciplinary team in California, has worked closely with a local oncology group who's participating in the oncology care model to support their patients. Over 300 patients have received enhanced services in the first 3 years of this program. Criteria for referral were high-risk patients, including patients with stage 3 or stage 4 cancer at the time of diagnosis, patients whose disease had progressed with metastatic disease to various organs, hospice-appropriate patients, elderly patients who live alone, and homeless patients who need increased social support. Through this team-based approach, with early goals of care conversations, assistance with completion of advanced directive, action plans to avoid the ER and hospitalization, 24/7 access to nursing care, results from this partnership showed reductions in acute hospitalizations and improved use and duration of hospice care. In addition, the patients reported a better understanding of their diagnosis, treatment, and day-to-day activities. Patients did not feel as alone, and they had less anxiety around their treatment. They felt empowered to actively participate in their treatment. Patients also were able to express an increased awareness of their treatment choices, their resources, and directions. And patients were able to limit their use for emergency department visits for non-emergent concerns and needs. I am very proud then to share that with the assistance through the relationship, the oncology practice in Northern California participating in the OCM was able to place 4th out of 176 programs in measurements to improve the quality of care for their patients. Thank you so much for your time.
My name is Shumulinsky. I am with the West Health Institute, a research and policy center focused on successful aging and lowering the cost of care. And I'm here to present an initiative that focuses on how MA plans and ACOs, accountable care organizations, are improving care for people with serious illness. Medicare Advantage plans and accountable care organizations are 2 valuable players in the healthcare industry today. They take on risk for a variety of populations, including those with serious illness. And there's been increasing interest in expanding the capabilities in palliative care on behalf of these organizations. And often it's become health plan and ACO-wide strategies. And there are proven strategies that exist for both health plans and ACOs to improve quality of care and cost of care for those with serious illness. And our goal is to disseminate these strategies to more health plans and more ACOs. And we did this through information sharing, peer-to-peer learning, guidance, and support from leading experts in the field. CAPC, the Center to Advance Palliative Care, with the funding and assistance from 4 major national foundations and research institutes, developed the first MA plan and ACO learning community focusing on just that. We recruited 44 organizations that covers more than 3 million Medicare beneficiary lives across 32 states. The learning communities focused on 4 main key strategies. One was on how to proactively identify the population in need of palliative care. Number 2 was how to use existing care managers to assess the unmet palliative care needs and clarify goals of care. The third is how to provide home-based palliative care to those in need of in a cost-effective manner. And number 4 is how to incentivize training and capabilities amongst the existing provider network. And you'll see on the poster that we use a combination of methods, including in-person and virtual convenings, one-on-one coaching sessions, and virtual office hours where the participants could get their questions answered by key experts in the field. And the interventions lasted between September of 2019 through the end of 2020. There were several findings that bode well for payers in support of palliative care from this work. First, all participating organizations were already trying some strategies to improve care with those with serious illness, and with proactive identification and home-based palliative care being the most common. The second most positive finding was that the learning communities successfully encouraged MA plans and ACOs to go and pursue more comprehensive strategies. For example, only 6 organizations in the beginning were focusing their care managers in playing a role in serious illness communications or palliative care referral. And after our kickoff session, the number of organizations increased in utilizing the care managers and that tripled to 18 organizations. The next was that interest in care managers was especially strong in using them to make appropriate linkages to home-based palliative care. And now with the existence of palliative care telehealth during COVID-19, a few of the organizations are now exploring how to make those linkages between palliative care and palliative care telehealth rather than home-based palliative care. And in terms of home-based palliative care, the learning community discussions revealed concerns about its resource intensity and that ongoing support was limiting access to new patients in need. And so there was rich discussions during the learning community convenings around how to modify the intensity of home-based care and how to distinguish between short-term transitional programs and ongoing care models. And so to wrap this all up, the participation in the learning communities by these 40 plus organizations have been found to bolster expertise and create a toolbox for providing high quality serious illness care benefits for 3+ million Medicare beneficiaries. And at the same time, the learning community conversations have allowed us to gather ideas and tips on how to overcome challenges. And we plan to disseminate all of these to MA plans and ACOs across the country. And CAPC plans to develop a suite of resources for all MA plans and ACOs to have access to. If you are a palliative care provider interested in collaborating with your own local ACO or MA plan, you can help them by working together to identify and engage appropriate patients, also by varying your services to meet both short-term needs as well as ongoing needs. And you may be successful in engaging your local MA plan or ACO to incentivize hospital-based palliative care. And finally, there might be opportunities to serve new patients via telehealth, but we'll have to monitor how that goes as the field unfolds. Thank you so much for letting us highlight our work.